Hello, dear friends. I would like to continue the large clinical case from which we can analyze total prosthetics to the patient with deforming arthritis with a sufficiently large number of complications that were obtained from previous prosthetics. We have discussed the diagnostic stage. Once again, if you have any questions, please write. We'll be happy to answer them. Planning stage. These two stages are probably the most difficult as they provide pinnacle of understanding the occlusion itself, the joint and work planning. And of course, a 10-minute video isn't enough to tell and understand all this in more detail. But I'd hope that I define the path to reflection for you. And then it's up to you, because the knowledge and experience you would like to gain you can only gain yourself. I can't do it for you, I can only help. Show examples and tell, reasonably explaining why we acted this way and what grounds and with what calculations. Because in dentistry there should not be something by accident. We should not expect that it is about to happen there by itself. Now we have to calculate everything, calculate even at a stage before our intervention or before we grab something, so that we can move on. So we have already advanced quite far, we have reached temporary prosthetics, we can take impressions and send our work to the dental laboratory to manufacture the temporary crowns. It is clear that the laboratory must be of a sufficiently high level, a very good laboratory. We send this work to another city so that everything would be very, very good. But even if you have a very good technician, colleagues, you shouldn't blame the technician for everything. You have to make good casts, make the correct registration, name of work, give color, number, and so on, but that's not all. Colleagues, you have to build the patient's occlusal scheme, give data and cities of the articulator. I think we'll make a special video dedicated to this issue. How to set up, how to register, etc. How to cast and why, and other technical questions so that you can check and control. Otherwise, if a technician does all this for you, then the technician quarterly will treat your patient for you, and this is fundamentally wrong. Then what we do is send the cast to the laboratory, we got the temporary crowns, and again we register the position of the upper jaw using the face bow and register the central ratio. We mount all this on the articulator, and please note that after sitting temporary crowns, not even in the articulator but in the oral cavity, what do I see? I see that the tilt of the teeth and the tilt of the crowns, which are done in the laboratory, do not match. The fact is that the inclination of the temporary crowns has been changed. They have a palatine deviation. What does it lead to? This leads to the fact that with lateral movements we have interference, and at the same time there is not enough density on the palatine tubercle. That is, this position of the crowns, colleagues, whether you like it or not, will lead to the fact that you'll have to make a flat occlusion. Pay attention on the lower jaw, the same thing. Patients' teeth have oral inclination, and the technician's crowns, for some magical reasons, are made straight. Therefore, once again, colleagues, even if you have the best technician, nowadays guys work very well. The level has grown increasingly over the past 10 years. They are really good ones. But all the same, control and responsibility to the patient is everything, and it is assigned to you. We start grinding the crowns, we mark and discuss with the technician the position of the teeth, mark the contacts, and once again we carry out the selective grinding of our crowns already in the oral cavity. Again, here the initial check is carried out using a 100 micron carbon copy paper. We mark those contacts on the antagonists and teeth itself. Pay attention, it is important for me that, remember, occlusal kung fu, The tubercle must enter the fissure. Therefore, I clearly understand checking the contacts where and what contacts I have. You see that these contacts are not enough. Somewhere I have point contacts and somewhere none at all. So I start grinding. For grinding special burrs, I use the abrasiveness can vary. The only thing is when working with plastic, if you take a low abrasive burr, it will stick there. Therefore, we take more abrasive burrs but work carefully because we have to grind within the micron. But if your hand trembles, then you can grind off the excess, and you can see that in some areas I do not grind but deepen the fissure because I see where the tubercle will enter. I have clear contact on the tubercles and it practically falls into fissure. So I take a little bit of the area from the vestibular side and here I deepen, so that the angle of attack is preserved and tubercle would definitely enter the fissure. Then I grind other teeth. I have additional contacts since I removed the earlier contacts, and guided by the logic of tuber fissure, I carry out further grinding. The next step is to use an 8 micron copy paper and check all the contacts again. Please note from the initial start I already have a lot of contacts on the super cusps. Here I see I need the contacts, and at the same time I got contacts on the vestibular tubercles. Once again I repeat that teeth there are, look at my fists, support cusps, and they enter the fissure. It is seen, understandably. If the inclination is oral, then they will enter as I'm showing you now. And if they are deviated like this, then what will happen to the cusps? I'm talking with the operator now. He is not a dentist, but it seems to me that this is clear and understandable, not for a dentist either. That is, if you have such cusps, you cannot direct them into a fissure. This tubercle falls into the antagonist tubercle. Where does it lead? To the cheap and unstable occlusion, because stable occlusion is when the tubercle enters the fissure. How to make this more understandable? This is difficult enough, but nevertheless, unfortunately, we get such kind of work after modeling, and we have to correct that in the oral cavity. This is important because you are responsible for this, not the technician. When the patient comes, you don't say that technician John did something bad to him. No, you are responsible for the work, and patients come after 5 and 10 years and begin to tell that something like in 1812 you somehow incorrectly made a crown for them. After all, we clear everything, look, check contacts. Sometimes I use Vaseline so that I can clearly see the contact. In general, in dentistry, it is very difficult to work without Vaseline, duct tape, super glue and a hammer, but one can. And then our next step. Once again, we check with an 8 micron copy paper, in this case blue one. You can see that I already have tubercles entering the fissure. However, there are areas where there are not enough contacts. In this case, this is the area in the left sector. And this is where a composite comes to our rescue. I clean the area where necessary. I provide a finish polishing. As you can see, the dispersion of this burr is soft. It is small because I want to get an uneven surface. And I start adding contacts to get them denser. I often do the final adjustment with just a polishing rubber. So, after providing the correction, we invite the patient again after some time. If something is needed, we correct it again. Once again, patients with temporomandibular joint dysfunction, especially if there are degenerative dystrophic process in the joint, have unstable occlusion. It's really unstable. It can change. The patient has certain unpleasant sensations, and you have to correct it periodically. And then again, I assessed the occlusal index, assessed the patient's spasticity, assessed the presence of pain. We removed these pains at the stage of preprosthetic preparation and no longer need them. If everything is fine, we proceed to the next step, taking working impressions for permanent prosthetics, and go directly to permanent prosthetics. So, dear colleagues, once again, what I want to summarize. The first step is diagnostics. Diagnostics is 90 to 95% of your success. You understand what you heal and then you make the right decision. The second step is planning, which is extremely important. It cannot be carried out if you have not made a diagnosis. After planning the third stage, in such patients, it is mandatory is spleen therapy, preprosthetic preparation. In any case, they are united by one name, preprosthetic preparation, because their main problem is not their T colleagues. It is TMG muscle dysfunction or physiological status, but not this. If you want to heal a joint, posture, neck, or something else with the help of teeth, then you probably will get a lot of problems and complications. And then, after you have registered everything, step by step, everything was documented, you have an improvement, the next step is temporary prosthetics. There are so many nuances here, you need to explain to the technician all the stages. You have another moment in which you start to have contradictions. This is a technical laboratory. It is not only a patient with whom you constantly communicate and who can offer you something of his own. And here you also need to speak the same language. You need to talk with evaluative characteristics. Here it is bad, here it is good. You must tell where to correct. That is, you must be able to control the work using the articulator. Have installed temporary prosthetics. It is not just for aesthetics, this is also treatment. Next, we assess the patient's condition, and only after that you can take the next step, a step towards permanent prosthetics, and then you probably won't get problems. Dear friends, we will take the next step in the next video. Please subscribe to our channel, like if something is not clear to you, for example, how much to wear temporary crowns or mouth guards. Many questions may arise. Please write questions, ask, we will be happy to try to answer them. We'll make new videos and thereby try to help you and your patients and help with complex occlusal issues. Thank you. I was glad to see everyone. See you.